Good morning, everyone, and thanks so much for joining this webinar on seating for neurological conditions, future-proofing your prescriptions. Very pleased to have Jo McConnell on again today. As you know, she's done a number of webinars for us now and has been sharing her experience as an occupational therapist with regard to specialist seating. Now, this webinar is brought to you by Vivid Care, and I'm Tristan Hulbert from Vivid Care. A little bit about us. We're a family business established in 1972, so we've been carrying out specialist seating assessments for over 30 years. All our chairs are made in Britain, and we work with loads of occupational therapists, physiotherapists, and other healthcare professionals and increasingly beyond. So we've got chairs in people's homes throughout the country, but also abroad, and then we've also got chairs in over 80% of NHS hospital trusts. So our chairs are in use all over the world, Antarctica, I believe, and we're part of the Core Care group with InnovaCare Concepts and Adapt. Now, some of you may have noticed, those that have been following us, that our flagship Lento range has just been improved and updated, and these are what they look like now later on in the webinar. But we've got a number of different chairs in the Lento range. They're all adjustable and they're all designed for different types of use, which we'll cover off. But I think the key thing that the Lento range really focuses on is comfort, and that's what we're really bothered about at Care. We can make such a difference to someone's lives with the right chair, and comfort is the number one thing that we focus on. Because if a chair's not comfortable, then what's the point? And I think we've covered this in a previous webinar about how comfort is clinical. You know, we often get involved in kind of the science of seating, the science of posture, etc. But comfort is really key, because if we're not comfortable, they're not going to get and they're not going to really be enjoying their time in a chair. So that's a really key point there, the comfort side of things. Just wanted to share our contact details here. Have a look at the website, there's a lot on there, and just wanted to put a note on there as to, you know, do book a product demonstration or assessment if you've got any client that you're struggling to see, or you want to try a chair with, or you want to do a bit of a training session for your therapist, then please give us a shout. We'd be more than happy to do so. Now, this webinar we'll be switching over to Jo very shortly, and then after that we'll be doing a short practical demonstration in our video room here, and then we'll move back together to go through questions and answers. So we'll have a live Q&A section. So please, as time goes on, please do put comments on the chat, questions, etc., and we'll do our best to cover them at the end of this session. The webinar will be recorded, and we'll be sending out the link to the video afterwards, along with any other resources that come up during our time. So without any further ado, we'll move on to Jo McConnell. Joanne's been a clinical team leader for a wheelchair service at an NHS trust for a while now, and she's been involved in specialist seating, in posture, etc., for over 33 years of experience across the NHS and private sector and charity as well. So over to you, Jo.
Okay, thank you very much. It's always a pleasure to do these webinars and share my passion for posture. So as the introduction says, this is another webinar that I've been asked to present for Vivid Care, but I am an independent therapist in this capacity. So here are the learning objectives that I'll cover in roughly the next hour. So what are we going to consider when assessing a client with a neurological condition? What additional challenges do these neurological conditions bring us? Key clinical considerations based on their clinical presentation, effective use of tilt and recline with the client group of neurological conditions, and how often should we review these clients? Okay, so that's what I'm aiming to cover, and lots of extra bits. Okay, next. So just trying to get rid of the box at the top because it's covering some of my slides. Thank you. So what are the seating challenges for neurological conditions? So with the umbrella term neurological conditions, which I'll come into later, we always have to look at changing needs. So what we will assess on one day may be very different on another day because they're progressive conditions. We'll always be having to consider the impact of tone management. This client group can very often struggle with difficulty adjusting to change, whether it's adjusting to a change with the prescription and setup of their seating, or whether it's adjusting to the change of their progressive condition. So there will always need to be an element of fine-tuning ability within the seating that's provided, whether it's wheelchair seating or home static comfort therapeutic seating. So keeping that in mind when you're the prescriber, when you're using your clinical toolbox to select the correct seating out of the wealth of choices that are available today, fine-tuning is always key with this client group. And what is their sitting tolerance? So sitting tolerance is very individual to each person, and it's also can change from day to day, morning to afternoon, and can be based very much around their mental health as well. So managing all of these expectations, it's not, that is one of the biggest challenges with this client group. I find this every day, every week, managing expectations of the individual, plus the family members, plus the MDT. Okay, next. So what is a neurological condition? So what I find is some therapists and some other healthcare professionals will see the term a neurological condition, the neuro team are involved and everybody will start to panic. But let's not just be drawn by the clinical diagnosis, but always by the clinical presentation. So a neurological condition is any condition that affects the brain, spinal cord, and or nerves. And there are over 600 different neurological conditions, and that is a ever-growing number. And we'll always come across a new neurological condition where there's no shame, quickly having to Google, what is this? I've not heard of this one. And there's so many very, very rare conditions out there. But just looking in the blue boxes, these are the main neurological conditions that we'll commonly typically encounter in our working days, weeks, lives. So CVA/stroke, cerebral palsy, MS, Huntington's disease, motor neurons disease, Parkinson's disease. They are the more common neurological conditions. But as I said, there's over 600 and growing. Okay. So seating. So we use this big term seating, and that's just one of the postures we adopt within our daily lives. But not everybody does or can adopt a seated position because they've been, the term I don't mind, they're bedridden. They can't come into clinic, they're bedridden. They can't sit, they can no longer sit. Sitting is no longer an option. So let's remind ourselves what seating is. So the activity is to be sat, and sitting is a basic action and resting position in which the body is supported primarily by the bony ischial tuberosities, with the buttocks in contact with the ground or a horizontal surface such as a seat or chair. So that is what seating is. I will see on a referral many times this person is unseatable. Unseatable, blimey, that is a big statement to make. So let's ask ourselves these questions. I just need to try and remove this box again. Is it safe for the individual to be positioned in a seated posture? So who is going to make that judgment? Usually the lead clinician in the team, but it will also be the individual themselves. They'll say whether they feel safe to be seated. It could be a family member, they're not safe in this seat. So in healthcare, and we're all very alerted and heightened to the term safe. Are we doing a safe action? Are we making a safe recommendation? What is the individual's sitting tolerance would be one of my biggest questions when I set out to do a seating assessment, whether it's for home seating or whether it's for wheelchair seating. So by that, I'll always be saying, how often are you able to sit during an average day, during a typical day? When was the last time you sat? How long did you sit for? Those are basic baseline questions. How long can that individual sustain an upright or semi-upright seated position? And does the individual need tilt, recline, or both? And I'd say with the neurological conditions, this umbrella group, this more complex group that we're dealing with their changing needs, I would say it's rare that they don't need tilt or recline or both, but tilt would always be the preferred postural option that we'd be looking at, for many reasons that we've touched on other webinars, but that we'll come back to again today. Okay, next. So why does somebody need to be seated? If there are other postures, being lying, standing. So it's to engage in everyday life, to participate. So if somebody's going to remain in bed the whole time, there will be some participation that they can be involved with. They can, be seated in a profiling bed, can't they? In a semi-seated in a profiling bed. So you can bring the head to an upright position. We can contour the bed to support the legs. But they can't do everything in that bed. They can't be involved in family life to the full, or they can't leave the house in that bed. So here are the important questions really that we need to again go through in our clinical reasoning. If there's difficulty with funding for seating, you'll be the clinician that's making the recommendation why they need seating. Can they relax in the seating? So if the bed is the position that they're in for majority of the day and night, they need a change of position, and we've discussed the profiling bed already, but they need to come out of bed into a supported sitting position. But it needs to be a seat that they can be comfortable, always, as Justin said, an important term that we should never say, I can't say that on a report, it's not clinical enough. They looked very comfy, they appeared very comfy, but if they are not comfortable, they will not use the seating. So can they relax in the seating? Are they able to socialise with friends and family, or just take part in their chosen activities? Do they feel more included in everyday life? I think they'll feel more, well, I know they'll feel more, and we would all feel more included sitting in a supportive, comfortable, seated position rather than lying in our bed. We don't want everybody coming into our bedroom to talk to us, do we? We want to go into other parts of the house. We want to watch TV. Yes, we can watch TV in bed, but that's, it's more of a typical thing to do that in your living room or with other people. Can they vary their seated position when needed? So can they make a choice if they only have the choice of lying in bed or coming out into a chair, a seat that they're not comfortable, they can't vary their angles, are they even going to choose to go to the effort of coming out of bed to be seated? And do they feel empowered to make the decisions about their posture when seated? Do they feel empowered to say, I just want to sit for 30 minutes, any longer is too long? But if they've got a care call that's 4 hours later, will they choose to go into that seat? If they're not comfortable in it, they may choose, I may as well just stay in bed and have my head raised in my profiling bed, because somebody's not coming back till midday and I can't sit in that chair till midday because it's not meeting my postural needs and I'm not comfortable enough. So these are all of the important reasonings we must do when we're involved, have the privilege of being involved with somebody's posture and healthcare needs. Next. So what are your seating goals? What is your reason for assessing this client for suitable seating, this individual? So we need to make sure in our seating goals we're always looking at the optimum posture, safe posture for that individual. So we want to create a seating position that gives stable posture and pelvic stability. We want to always be at the forefront of our goals to minimise the impact of pressure risks. Done other webinars, and we're all aware of the huge implications of pressure injuries on the skin, on the seated surfaces. So we need to always minimise the impact of pressure risks. We want to achieve symmetry in the seated position when possible, or as much symmetry as possible. I've talked in other webinars about when a postural deformity is fixed versus flexible. So if we have a fixed postural deformity, we need to achieve as much postural symmetry as that person can achieve. We need to maximise the individual's comfort. We know that comfort is individual to each person, but we need to make sure that that individual can tolerate the seat because they themselves feel comfortable, they feel safe. We need to reduce the impact of developing further postural deformities and to manage the postural changes with these fine tunings that I was talking at the start. And we need to enable functional movement, as much functional stability as possible, and as much proximal stability to give us distal control. So when they're in their chair, can they reach out of their base to reach over to get their cup of tea or to pick up their mobile phone? So we need to enable functional movement through the correct level of support, and always increase the sitting tolerance and participation in everyday life. The effort of somebody having full hoist out of bed into seating to sit for 30 minutes, you need to sometimes weigh up the pros and cons of that in their care package. So they need to be able to maybe start off at 30 minutes of sitting, but have a goal of how long will they remain sitting in that chair? Will it be until their next care call? Will it be just an hour and a half if somebody's popping in? So all these goals need to be agreed with that individual and manage their expectations. Okay. They won't be sitting on those orange chairs, by the way. Next. So first of all, we need to identify what support does that individual need to have a successful seating outcome for their individual needs. So with that, we'll be needing to select the correct accessories that will provide that individualised and bespoke postural support. We need the ability to adapt their seating for their changing needs. As we've said, they could be different in the morning to how they are in the afternoon. They could be different later in the week to how they are the beginning of the week. So with neurological conditions, there is a lot of change and a lot of often advancement in the progression in the condition and deterioration with the condition. So these elements all need to be high priorities on your clinical checklist. Okay, next. So let's remind ourselves of some key posture presentations affecting successful seating outcomes. So there's, on a webinar like this, there'll be all sorts of different levels of experience and confidence with seating. So some of this will be very bread and butter stuff to a lot of you, but I think when we're talking about, never mind neurological conditions, any condition, we have to come back to basics. What are our key presentations within posture that will affect successful seating outcomes? So let's just have a little recap of those. Okay. So posterior pelvic tilt. This, in many conditions, not just neurological conditions, will be a challenge within seating. And I usually at this point have my pelvis and look at the different alignments of the pelvis, but let's just look at the images today. So in posterior pelvic tilt, the pelvis will not be in a neutral upright position. It will roll backwards into posterior tilt, and we'll tend to then be loading on the sacrum and coccyx. And this will have many impacts on the individual's body presentation, but also on the seating setup. So if we're less experienced and less observant, it will make it appear that the individual has a longer seat depth than they actually do, because their pelvis would have rolled forward, as you can see in the first image, leaving a gap, sometimes a significant gap of up to about 3 inches behind the individual's furthermost point in their body to the back support. So a simple check here will be, can I get a hand behind them? So you may have to remove armrests, and you will obviously be describing what I'm doing now. I'm checking for where your pelvis is sitting in the seat, how you're presenting to me now. And then you will always feel there's a big gap behind the person's bottom. And they may then be saying to you, or a family member may be saying, the seat depth is way too short for them. They're just way too short. There's a huge gap behind their knees. And then you'll explain that's because they're not right back in the seat. Their pelvis has rolled and it has actually left a gap behind. So this illustration here, very simple illustration, which we've seen before, shows that gap that we're feeling for. So that will impact on how the rest of their body presents. It may be that they'll always be in a posterior pelvic tilt, that has now become quite fixed, and then we'll have to work around that. But always the goal will be to get them hoisted in again correctly, and guiding their pelvis to the back of the seat, so that they're in an upright position, and providing a cushion that has contours to actually support their pelvis in that pelvic well and help maintain their pelvis in a more upright, neutral position. So if they do remain in posterior pelvic tilt, it will impact on the shape of their spine. So typically we'll see that their spine will adopt a more flexed kyphotic posture, which obviously will impact on head positioning and all of those things. It can also affect how the legs will present on the cushion surface, and we'll often see hamstring shortening when there's a posterior pelvic tilt, which all of these simple things, how the pelvis is positioned, is so key. And this is why it's my starting slide about the postural considerations, because if the pelvis isn't supported in as neutral, upright position as possible, it will impact on your whole outcome of what you're trying to achieve. Okay, next. So then we'll be looking for somebody from the front and from the rear, and we'll be feeling, again, I'd normally have my pelvis, we'll be feeling their pelvis, and we're saying, is their pelvis level? Or am I feeling that one side of the pelvis is higher than the other? So always at this point, it's good, you're having a little sit down, a bit of CPD learning time. Feel your own pelvis. Put your thumbs on your own pelvis now, on the bony part at the front, the ASIS. Put your thumbs on there and just shift one side of your pelvis higher than the other and feel how that impacts. So what you're trying to feel on the individual when you're assessing them Is one side of the pelvis higher than the other? And it's a really good thing to do with the thumb check. Is one thumb higher than the other when I'm placing my thumbs, with permission always, on the individual's pelvis? Do my thumbs look level, or is one thumb higher than the other? And that is as simple as it can be. Don't be afraid to get hands-on after asking permission. Can I feel your pelvis? What I'm feeling for is to check that your pelvis is level. So in this image here, you can see that the pelvis isn't level. One side's higher than the other, which may be fixed. It may be correctable. We're not going into a full cushion assessment here. These are things to look out for. But obviously, if the pelvis is oblique, one side higher than the other, we will note that in our clinical notes. We'll say pelvic obliquity, right side raised, and then you'll do a rough guesstimate of that. And you'll note that we need to see if we can correct that within the cushion, because it will impact on the spine presentation if left. Again, if you're doing a full postural assessment, my advice would always be to somebody with more complex posture, you will be doing an assessment in lying and sitting, because then you only then do you know if something is flexible or fixed. But I know in all of your workplaces that isn't always possible. I'm lucky to work where I have a plinth and full postural assessment equipment in clinic rooms within the NHS, and I'll do always an assessment in lying and sitting to establish what is fixed and what is flexible. But these are checklists for you when you're thinking about what are my postural goals. Okay, next. And looking at supporting the upper legs, the femurs. So this image, this illustration will show us what neutral hips would look like. So just again, look at how you're sitting yourself. Where do your legs naturally fall? We don't sit with our knees close together, do we? Unless we're choosing to do that. We sit with our legs just a comfortable thigh width apart. So the goal should be to keep the femurs in nice neutral alignment. That would be what we would be aiming for. But many individuals that we see with neurological conditions will present due to many reasons. It may be due to tone. It may be due to limitations in their hip range. It may be due to pain, that they could be sitting with their legs either very tightly together, adducted, or with their femurs rolling outwards. So we need to establish how far off neutral are they, what can they tolerate, and what can't they tolerate. So this is your baseline. What am I looking for? So that is the goal, to keep neutral hips whenever possible. Okay, next. And then looking at rotation of the pelvis. So let's not confuse rotation of the pelvis with wind sweeping. They're very different things. So rotation of the pelvis, we will need to look at the individual in different planes. So I would say, again, always looking front on at the individual. You may think, oh, there's a leg length difference. It often is not a leg length difference. It'll be that the pelvis is rotated, so one side of the pelvis is forward to the other. So again, try that yourself. Move one side of your pelvis forward, and it will appear that one leg is longer than the other. So is correction available? Can you correct? Can you manipulate and bring their pelvis back to neutral? Is it that they've just been poorly placed hoisted into the seating? Is it that actually when we hoist them up again, bring them back, we can derotate their pelvis and actually get them into nice neutral and remove the pelvic rotation? It's sometimes as simple as that, but it could be that the tone imbalance, it could be that there's a hip limitation on the one side, it could be that the hip is actually subluxed or dislocated due to weakness on the one side. So it could be that is the position we're working with. But if we look at them from up above, stand up above them and look down their back, move them slightly forward, and you'll see that, again, feel with your hand, put your hand in, don't be afraid to be hands-on. You'll feel there will be a gap behind one side of the pelvis versus the other if there's pelvic rotation. So again, use all your key observational skills, note everything down to remind you, because you won't remember all of this when you leave, otherwise there's too many things you're looking at here. Okay, next. And then wind sweeping. So as I said, don't confuse pelvic rotation with wind sweeping. So with wind sweeping, if you were to do the looking up above, down the back, you would see that both sides of the pelvis are level at the back. So if you put your hand in now, you'll feel that they are making contact with the back cushion, their back support surface, because the pelvis is level. But you'll still see that there could be a leg length difference, but you'll often see that both hips are falling turned to one side. There'll be often a hip pain involved. There could be, as I said, dislocation, subluxation. It could be due to tone, often is due to tone. But it needs to come back to what can be achieved within this seat. It's not all down to the seat. It may be down to tone management. It may be that there's an orthopedic consideration. And it's definitely down to looking back what's going in bed. So what is going on with nighttime lying positioning? You cannot achieve everything within this seat and then expect that person to tolerate that when they lie 12, 14 hours a night in a poor position without support in bed. Okay. Next. So as I said about this in the other slide, when we haven't got neutral femur alignment, when we haven't got our neutral hips, we will see one of these positions, which I've already discussed because I've jumped a bit there. So we'll have adduction of the knees and internal rotation. And then we'll need to look at how we're going to accommodate that and support that more neutral alignment within seating. Or it may be that the second picture, the legs are turned out, externally rotated and widely spread open, and that's abducted. So again, this can be difficult to support within seating. So we need to know what can be achieved, what can be corrected, and what can be tolerated. And how are they lying in bed? How long has this gone on for? Is this a recent thing? Has it been like this 2 years? Okay, next. So let's look at some scenarios here now. Some of the things that will be said to you every day, multiple times a day, and what you'll read in people's notes. So we'd like a review, we would like a new seat, we would like a consideration because the client slides forwards in their chair. How many times could we have bought ourselves many nice things if we had £1 for every time that was said to us? I know I would have quite a wish list by now. So poor posture, such as slouching or sacral sitting, which we know is posterior pelvic tilt. So it will lead to many other implications if we do not resolve this. The skin integrity will be definitely compromised if somebody's sliding forwards in the chair. So let's get our sort of investigation toolbox out and let's look at basics. Don't be scared just because it's a neurological condition. Don't be scared. It will be the same. Almost take when we're going through our checklist, when we're going through our detective assessment stage, don't get hung up on the diagnosis. Look at the clinical presentations, okay? Because people will sometimes bamboozle you with, well, they've got motor neurone, they've got this, yes, I've noted that, but I'm looking at how they clinically present. So don't get hooked in on this clinical diagnosis. Always be mindful of it, because of course we'll know how it'll impact their life expectancy, etc. But look at their clinical postural presentation. So measure, is the seat depth adjusted correctly for the client? So what they've said, it's way, way, way too short, this seat depth. They can't sit safely in here. It's way too short. They're going to fall out. Actually, what's happened, they've got posterior pelvic tilt. They haven't been hoisted well into the seat, and their seat depth is not too short. So that's usually a quick fix. And the correct seating will have adjustable seat depth that can easily be changed. If we're looking at a younger person, they may have grown. With adults, they won't have grown. So that's an obvious state. So assess for the correct contour and pelvic well. hold that pelvis in a nice neutral upright alignment when possible. So if you think back at one of the early pictures I showed with that person, posterior pelvic tilt, and they weren't being supported within, there wasn't an ischial shelf to hold their pelvis in an upright position. So make sure, there's very few people that will sit, even ourselves, we won't sit that comfortably on a completely flat surface. Our bodies are not flat. Our pelvis is not, needs support. So provide a suitable padded pelvic belt, pelvic positioning belt to support the pelvis. So what pull do we want on that belt? Do we need a 2-point pelvic belt? Do we need a 4-point pelvic belt? What angle of pull do we need? So is the pelvic belt doing anything at all, or is it just being used like a loose, saggy lap belt, which is not a positioning, that is not for a postural positioning aid, that is more of a just keep them, put it on as a point of thing. We've put the seat belt on. It's not a seat belt, it's a pelvic postural accessory. So support, make sure the feet are supported at the correct height. If the feet aren't supported at the correct height, again, many individuals are saying, don't like using a foot plate, don't know, it's a foot support. So it's part of the postural components of the seating system. It's not a foot plate, it's a foot support. So it needs to be supporting the feet at the correct height. Otherwise, they will slide forward in the chair. And try using different elements within the seat. If they haven't had the opportunity to use tilt before, try using some tilt. So all of these are just basics that should solve sliding out of the seat, which is one of the commonest things that many of us will get called back for. Okay, next. So leaning posture. So select options and accessories based on the clinical presentation, again, not based on the condition. Why are they leaning? Do we know whether they actually have a scoliosis that is fixed? So actually they'll always lean because that is now the shape of their spine. There's no more flexibility or correction available. There's no planned surgery, and they've been like that for a long time. So if they're going to be leaning because of that, we have to work with that. So it may be that the client has poor trunk control, which many of the clients with neurological conditions will have poor trunk control. They are struggling to maintain midline position when seated because they don't really know what their midline is anymore. So if we're looking at the ideals of our midline versus their midline, they're very different things. In a clinical assessment, I will always, when possible, have a long mirror available, and I'll say to them, let's just have a look in the mirror. How do you feel you're sitting? I'm sitting midline. Right, should we have a look in the mirror? And then sometimes it's actually quite sad. The penny will drop. I go, oh, I'm not. So I'm here. My head's here. My trunk's here. But they're so used to thinking they no longer know what their midline is. So it's a realization. And a lot of them will say, I don't have a mirror like that at home. I haven't seen myself like that for a long time. So another part of the assessment, do they always lean to the same side? If it's a fixed postural deformity of the spine, that will be yes. But if it's leaning because of fatigue, pain, weakness, it could vary. Does the leaning vary from day to day? Is it when they haven't slept so well, they're leaning more? Is it when there's a medication change, they're leaning more? Is it that in the morning they're really upright and alert, in the afternoon they're so fatigued, they're leaning more? And all of these things, otherwise, if you just take a snapshot, what is the problem? I'm leaning. We really haven't addressed the issue. We do have to allow long enough for these detailed assessments, and also make sure we're asking the correct questions, we're doing the correct observations, because sometimes they're so fed up, they're in so much pain, they've had enough, that they just will give you throwaway answers that can, if you're in a hurry, can lead you to the wrong conclusion. Okay. And let's look at some solutions for leaning posture. This lady looks very comfortable there, by the way. what are our solutions for leaning posture? They will be different for different clinical presentations. So providing adjustable lateral supports. Can the individual even tolerate lateral supports would be my question there. So many individuals that I work with, that I'll go through all the reasoning. What we need to do is to support your trunk because it's too much work for you as it is, and this is why you're leaning. It's too tiring. Then you want to get out of the chair. When you're leaning, you're then trying to do a little shift to correct yourself, and you're shifting your pelvis, and we're all going down a spiral of it. Nothing's well aligned. And then it will be, I can't tolerate lateral supports. They're just too uncomfortable. So it could be that they've tried a poorly positioned, a poorly padded postural support in the past, which was too uncomfortable for them. So you have to say, well, every seat's different and every postural element can feel different. So let me show you what I've got today. But it may be that they actually prefer to feel a more lateral prompt than a lateral support. So they need to immerse into the back. As I said, nobody's backs are flat. If we're putting somebody against a hard, flat back, that's not going to work. And then if they've had a hard, flat lateral, that's not going to work. And that will be their memory of a lateral support. It may be 20 years ago when we didn't have the choices that we have now, when we're working with some of our clients who are in their 60s, 70s, how much of products changed in that time. In wheelchairs, it's unrecognizable, and also in home and supportive seating, it's completely changed. So their memory could be based on, oh no, I can't tolerate that. I've never got on well with a lateral support. So it's about being kind, patient, and showing, oh, that's really different now. Have a feel of this and that sort of thing. So do they need two laterals? If they've been pinned in by two laterals, do they need two laterals? Would one work? And does the back offer enough immersion into the foam surfaces that would give a more of a natural lateral prompt? Are you using tension adjustable straps to allow space for them to immerse? And looking at seating function. So if they've just had lateral supports in a very upright position, that will be hard work. That will be tiring. So do they need tilt? Do they need tilt with a bit of recline? So all of these are solutions when they're offered correctly. Okay. So how many times will you see you've been requested to go and review an individual because of their head? And how many times will you have on a referral or on the phone, can you just sort my head out? No, will be my answer. I can review your head positioning for your head support. A pet hate of mine, I'm just going to say it now, is headrest. When people say the term to me, headrest, I go, that's for a car. That is in a car. When we're talking about correct postural support, it's head support, like foot support, back support, arm support. Let's give these postural elements and accessories the respect they deserve, and our clinical reasoning and skills, the respect they deserve. Sorry, it's a soapbox moment. So I hate the term headrest. And when people say my headrest is wrong, well, you're not traveling in your car. It's a head support. That's why we need a detailed analysis of what is going on with your head to really give the correct support for your head. So limited head control versus no head control. So it will often be, you need to come and see my mom, can't use that seat, whether it's wheelchair or home seating, because she's got no head control. Right, okay, I'll come out and do a complete review, or they're going to come into clinic and we're going to do a complete review. So what do we all mean by no head control versus limited head control? They're two very, very different things. And what posture we'll be looking at them in to come up with that conclusion. So there will be individuals who have no head control at all. So they'll need a full head support with a lot of postural elements. They may also need chin prompts. They may also need forehead prompts. They have no head control. But somebody with limited head control, there's a lot we can do with them. There's a lot of adaptations we can make to the whole overall back support to give the stability for the head, but we cannot just sort my head out. So this is a whole other course, by the way. It's a whole other webinar, and I'm sort of on a soapbox moment, but the individual has to have the ability to accept the head support you're offering. They need to know that there is not a quick fix to this. It will involve other postural analysis, postural elements. And when we're getting into the realms of highly specialist bespoke head supports, that is a very detailed assessment that's needed, because the head is heavy. Our heads are really heavy. And for our clients, individuals with neurological conditions, think of something like MND, for example. The head is so, so difficult to support. I saw somebody 2 weeks ago, actually, at work in the NHS with leukodystrophy, and the most difficult head I've ever worked with. So I've tried now 3 different alternatives, and there has to come a time when we accept there's a limit to what a head support can do, and when medical intervention's needed, either by a orthotic collar or medication, and a combination with the addition of a correctly assessed head support and the correct seating and the correct angles, and increasing realistically their sitting tolerance. The head can take up hours and hours and hours. Sorry, I've took hours and hours and hours on that slide. I will move on to the next. So supporting the lower legs and feet. So as we've discussed in some of the other slides about postural presentations, the lower legs and feet need to be supported in as neutral alignment as possible. Otherwise, this will compromise the pelvis and spine. So when somebody says to me, I just can't use those foot plates, I'll go foot supports. Yes, I just can't use them. And I've took them off and I'm just letting my legs hang because it's just more comfortable for me. I'll say, okay, I get that you've got other limitations. There may be leg ulcers that need medical intervention. There may be very swollen lower legs with edema. But if you're not going to support your lower legs, we're going to impact on the rest of our seating outcomes. So we're going to impact on the pelvis, which will in turn impact on the spine, which will impact on our trunk, on our leaning, on our head, on our function, on our speech, on our eye contact. We have to support the feet. We have to support the lower legs. So provide seating that will do that. Provide seating that is adjustable, that will have a foot plate, a foot support, just testing, that will have a foot support that will do that. Don't look for quick fixes with something you found in the store at the community equipment store, or something they've dragged out of a cupboard in a nursing home. If you're putting your name to that clinical assessment and that clinical recommendation, know that you've done your best for every part of their seating setup. And that includes supporting the feet and lower legs. So this is so overlooked. So make sure you're selecting seating that can support that. Okay, next. So how often do we see clients with knee contractures? Very often will be the answer, and especially with this neurological client group. And it may be the reason that they're having difficulty tolerating their seated position due to tight hamstrings. So this individual may be that sad case where they've been in bed for such a long, long time. So then to try and support them in seating can be very, very difficult. So the seating needs to have adjustable foot support, which may be in the form of a footboard, to support the knees and lower legs using a negative angles of the leg support. The leg rest I've written there. So you may need to make sure that the support surfaces are soft enough on the seated surface, the cushion, and it may be that should be that the front edge needs to be contoured. It could be that it needs to be gently cut back to allow for these very tight hamstrings and these angles and these knees that just aren't used to being in a seated position. So if somebody's been lay in bed for a long, long time and will continue to be lay in bed for a long, long time, a lot of hours in the day, they need nighttime positioning. It needs to be combination of 24-hour postural care to look at being able to support this individual comfortably, appropriately, safely in seating. Of course, somebody will only want to sit for 30 minutes if they're in that much discomfort. Why would we want to sit for any longer? So we need seating that will be able to easily be changed. Hopefully the lower leg positioning will improve. What medication are they on? Has that been reviewed? What is their toe management? What's in place there? Have they had a review? Hopefully, if a neurological condition, they will be involved with the neuro team, the neuro physio OT team. Do referral back to them. This individual has having compromised quality of life because they can't easily sit, tolerate sitting because of their tight hamstrings. Be as direct as that. And essential is in-bed positioning for supported lying. It should not just be children that have sleep systems. It should be any individual who is compromised. So we are in a broken system when it's just, oh, you can only get a sleep system for a child. Right, okay, so they're miraculously needs going to go away when they become an adult. So if they were lucky enough to have a sleep system as a child, they can keep it as an adult. But, is it still appropriate? Who's reviewing that? They need support in supported lying, or we cannot achieve our realistic goals for them in supported seating. Okay. So successful toe management and how this impacts on seating. This is a really interesting topic and something that we all need to be more involved with. So I've been to some great talks actually in the last couple of years. I'm not an expert on spasticity toe management, but I come across this every day as challenge in my work life. So we need to very much put it at the forefront of our assessment rationale, our assessment process, and to know where we start and finish with what's achievable with our impact. So if we look at the World Health Organization, ICF, and we look that it's highlighted in chapter 7 that tone is classified under body functions in chapter 7 of the ICF, and read that if you have time. Go and read it and understand how impactful and harmful it is on seating outcomes if tone management is not successfully addressed. But within there, it's saying that the impairment is the muscle spasms, and the effect and how this impacts on seating and our seating outcomes for our very complex users, individuals like we're talking about today, is massive. So pain, difficulty tolerating seating. We'll have tried every tool in our clinical reasoning toolbox, but we can't change everything if it's down to tone. So sometimes we have to step back and say, there must be a specialist spasticity team in my region that this person needs to be referred to. Then we can address what we can do with seating. So how it impacts on seating is tremendously. So I just wanted to put this slide in to say, don't be afraid to say, we can't achieve this without some further impact on who is managing your tone. So with this neurological client group, again, as pediatrics, cerebral palsy, we will all be comfortable with talking about, do they have tone management, and have they got a baclofen pump? Do they have this? Do they have that? But with our adults with neurological conditions, who's keeping an eye on that for them? Who is in charge of that? Have they been referred to the specialist team? So, and knowing where our impact is going to be stopped and limited because of tone management is really important to sometimes say, we can't change this until something happens with this individual's tone management. Okay, next. So the spasticity management options. So postural management is certainly an element of that. which will include where we are today, talking about successful seating outcomes, and always asking the question, if that's not in your toolbox of what you're able to offer asking the questions and referring on, and making some noise about supported sleep, supported lying for the day and night. We can look at dynamic elements within seating. Sometimes in some seating systems, we can have a dynamic back for those that really need it, a dynamic footboard, foot support for those with such high tone. Not possible in every seating system, but certainly that is an option out there when needed. Is it specialist orthotics that's needed? As I spoke about the gentleman with leukodystrophy, and there is no head support out there that will support this individual safely and safe swallow. He needs an orthotic specialist collar, and then we'll look at supporting with head supports. What rehab are they getting, if any, sadly? What is the therapy input? What are the goals therapeutically? And what prescribed medication are they having, if any? Has that been reviewed? Is it oral, local injection, surgical intervention, baclofen pumps, etc.? Pros and cons of medication regarding seating and everyday life is that correcting or realigning a tone can also have an impact on function, and that they may be thriving on some of their function with their increased tone. When we lower that tone, manage that tone, sometimes they will lose function. And I've observed that in some cases, and then they've decided to live with the higher tone, increased tone, because that gives them the function. But these are all bigger questions than what can a seat do. But really, really interesting for us all to be involved with that conversation. Next. So just really, I'm sort of rounding off here. I feel like I've waffled quite a lot today. Hopefully it hasn't been too difficult to follow, but just some statistics really about the average person sits down for 4.7 hours per day. And when we're saying the average person, we're saying the typical person who is does not have a disability. So representing 47% of the global adult population. And this was from this very detailed worldwide surveillance of self-reported sitting time, a scoping review. So that to me is really, really key here. We're saying a typical person on average, and that's a person going to work, driving their car, all the activities they engage in during the day. And then we'll be dealing with people that have zero sitting because they don't have a suitable seat and they're expected to be in bed all day. But on the other hand, we'll also see the people that want to stay in their seat all day long because it's the only place they feel they can breathe, they can be comfortable. So it's just getting in our heads how important seated posture is and what a fundamental part of our responsibility that is also. So just taking more time to ask those questions about what are your seating goals? How long are you sitting at the moment? When was the last time you were seated? When was the last time you actually felt comfortable and safe and supported in seating is so important. And setting realistic goals, achievable goals with that individual, but also with the MDT, with the family members, and using that when somebody's over-sitting. So I see people that want to sit in their wheelchair for 12 hours a day and then wonder why they're uncomfortable. But I also see people that don't get out of bed and can't tolerate sitting more than 30 minutes because it's never been correctly set up or prescribed or reviewed or understood what that person's difficulties are. Okay. And just, I like some of these always remember comments. So supporting quality of life and independence involves recommending the correct specialist seating. So even if you're going to make that recommendation, but you know that is going to get turned down somewhere, you know that you've done your best job by that individual. You know that you've set out, these were my goals, this was what is achievable, and here is the solution. How that is taken forward is sometimes out of your hands, because that may not be funded, but you have done your best by providing the best outcomes and proving solution, clinically justifying that solution. That is your goal that is your role as a therapist. It's a privilege. Good posture begins with a stable pelvis and a comfortable seated position, helping the person feel balanced, secure, and ultimately safe. So always remember those things. And don't be scared of the diagnosis. Okay. And some takeaway thoughts for individuals with neurological conditions. I'm hoping that I've covered all of the aims of my session. I'm just quickly checking. Generally, this client group are unable to reposition themselves into an optimum posture to alleviate discomfort. I think we'd all agree there. Some of them will try and adjust and switch their posture, but typically this client group will need assistance to do that. So we want to place them with our recommendation into the best seated position we can get them in, with the most suitable seating, with the most future-proofed options, with the most comfortable outcome, because then we've done our best. So for these individuals, effective postural management plays a crucial role in their healthcare and quality of life. So let's not ever forget that seating assessments are a fundamental postural outcome, is part of their healthcare. It's as important as any other element of healthcare. Utilising appropriate specialist seating can support the maintenance of optimal seated posture, which will safeguard their physical health, but very, very importantly, their mental health and emotional well-being. The amount of people I see that have been in bed for years and years, and their mental health is as low as can be. And the comments I have said to me is so sad, that I have not left this bedroom in 4 years. I have not been seated in all of that time since I was discharged from hospital. So that is a healthcare crisis, in my opinion. So this approach can enhance overall quality of life and promote greater independence, obviously. So prolonged bed rest is seldom a viable long-term option for a purposeful life. So that is why we train to be OTs, isn't it? Not to just tick a box and say, well, I've been to see them and actually they're in bed and they can't be seated. So yeah, we'll have to move along to the next one now. That's not why I trained to be an OT anyway. So yeah, that's another soapbox moment, I'm afraid. So some takeaway thoughts from me. Your takeaway thoughts may be different, but maybe some of the things I've said have sort of settled, and you think, yeah, that's something I can adopt in my future practice with this complex client group. Okay, I think that might be me. You'll be glad to know. Okay.
No, that was fantastic. Thank you very much, Joe. And certainly agree with what you said at the end there. We often see people that are just they've been stuck in bed for months or even years in some cases. And what kind of quality of life is that? So it's key to try and get the chair sorted out, try and get some seating sorted. So the next stage of this webinar is a brief practical demonstration of some of the chairs and linking them through to what we've talked about, what Joe's talked about, and then we'll be back here doing a Q&A section at the end. So please do put questions on the chat here. And we'll cover them off at the end. So just bear with me a moment. I'm just going to move to our video room and show you some of the chairs and chair features that would link with what we've been talking about. Hello everyone, hope you can hear me okay. So we're just in the video room here, and as I mentioned before, we've recently upgraded our Lento chair range. So we've got many new features. I won't go through all of them now, and we've got a new chair as well. But I really wanted to take this time just to cover off 3 chairs that we often use for neurological conditions. So one of them is the Lento mobile chair. So this is actually a rise and recline chair, but it's kind of a cross between a care chair and a rise recline chair. So you'll see, despite it being a rise recline chair, we've got portable wheels on the bottom, and a push handle on the back, so we can actually wheel a client around. But we've also got the ability to do multiple transfers with this multiple types of transfers with this type of chair. So obviously we've got the riser action, and there's a bit of vertical rise in the action at first as well. So we can do independent standing transfers, but we've got removable arms as well, so we can do side transfers as well. And then we've also got the ability to hoist in and out, and also it's Sara steady and that type of equipment compatible as well. So the point of the mobile chair really is to give the support and comfort that a care chair gives, but allowing for a lot of different types of transfer. And the reason I've kind of wanted to talk about this particular chair is because with neurological conditions, particularly with conditions such as Parkinson's, you tend to get a lot of varying kind of abilities throughout the day or over time. So we might have someone who's able to stand in the morning but can't manage to in the afternoon, or we might have a progressive condition that deteriorates over time. So we might go from standing, and then we might have to start using a transfer aid onto a stand aid, and then maybe to full hoisted. So it's a very flexible type of chair, and it's kind of a good option if you're not sure what kind of chair might be suitable for that client, simply because they are very changeable. Someone's just asked how easy it is to take the arm on and off. So very simple. There's a screw knob underneath. You just slacken that off with your finger, and then the arm just slides out like that. So you can see you've got access to do a side transfer from side to side, and then you can just put the arm back on there. Now, with all the Lento range, all of these chairs are adjustable in size. So we've got seat width adjustment, we've got arm height adjustment, we've got seat height adjustment and seat depth adjustment, all without tools, and they can be changed in just seconds. So seat sizing is absolutely critical for posture, pressure care and comfort. It really is a key aspect to get it correct, so that someone's posture is correct. So that's why we have all the adjustments within all the chairs in the range. So that's the Lento Mobile, good for different types of transfers, great for things like Parkinson's. Now, this one here is the Lento Neuro, and you'll see it's quite different to the other chairs we've got here. And we initially first developed the Lento Neuro for those with Huntington's disease. So if you've ever come across anyone with Huntington's disease, it's a terrible condition. You've got a lot of involuntary movement, which gets worse and worse over time. So what you've got here is a chair with a lot of seat rake, so a large angle on the seat, if you like, so that someone's down into the seat in a very safe position, and they're close to the floor. But also with the involuntary movements, you'll find a lot of the chairs on the market for this type of condition, they're made with very strong metal frame, and rightly so, because they do get a lot of kind of grief, for want of a better word, because of all the intense involuntary movements throughout the day. But what we actually found in our clinical trials is that if we could actually cocoon and provide a soft space, so we've still got the strong metal frame, but if we can provide as much padding as possible within the chair, that sensory input actually really helps calm down the movements. So we found this to be really successful, not just for Huntington's disease, which was what we originally developed it for, but also for things like dementia, where you need that calming kind of cocooning, soft type of abilities there. Now, all three of these chairs have got tilt in space, but this one does it slightly differently. So we've got what we call a front pivot tilt in space. So the pivot point is actually at the front. So when it tilts, you're actually going like that. So we're coming further down, closer to the floor, and providing that tilt, bringing someone back into the chair, keeping them in an even safer position, but they can still see around the room, which is really important for keeping that interaction. So that's the Lento Neuro, and it's got a foot block in this configuration, but you can have a low foot plate if you wanted to, if it's someone who wants to kind of keep their feet grounded on the floor. For Huntington's, we tend to prescribe this foot block, but for dementia, we tend to do the lower kind of footboard often. And then the final one I want to talk about is the newest chair in the range, which is the Lento Cove. And this is a care chair, tilting space care chair, backrest recline, as you'd expect, with all the adjustments, size adjustment, arm height adjustment, width adjustment, depth adjustment, foot plate height adjustment, leg elevation, tilting space, etc. But what's different is obviously this backrest here. So on each of these arms, we've got multiple different positioning points. You've got up and down adjustment on each section. In the back alone, you've got over 2 quadrillion different adjustments you can make. So the configuration is unbelievable. But despite that, it's easy to actually get it right for someone to follow that spinal position. So this is really for the complex needs. But as well as it giving support, it's actually very soft as well and comfortable. So we've got like a soft fibre-filled type padding in here. So you've got the support of the metalwork behind, but then the softness on the front, which I think you can obviously see that we really are bothered about comfort here at Vivid Care. So we've spoken about the sensory input here, having a metal frame and then the softness around it. We've actually got a similar kind of thing here. So we've got a backrest that can really follow the shape of someone's posture, help realign them if possible, or support them if not, if they've got a fixed posture, but with softness as well. So I just thought I'd cover off 3 of the chairs in the range, just some of the ones that we specifically tend to look at for the neurological conditions. Now, obviously, there's a lot of different neurological conditions, as Joe's been talking about. So these are quite varied in what they do, but hopefully it gives you a bit of a picture as to what you might want to look for, and what's available, what's out there. So I'm just gonna mute now, and I'm just gonna pop back upstairs, ready for the Q&A section with Joe. Just bear with me a moment, thank you. For your patience there, everyone. So, over to the Q&A section. So one from Natalie here. As a TVN, pressure redistribution is very important to me. Is that incorporated into the seat or as additional cushions aids for high pressure relief? Do you want to start off on that, Joe?
Every case will be individual. So for the higher risk clients, users who may have a history of pressure injury or an existing pressure injury, there'll have to be an agreed plan in place. And I would say that it may often involve very agreed limited sitting times and safe levels of sitting agreed to what stage their injury is at. But I don't know what you feel, Tristan. I would say it would be an air product that you could replace or implement into the seat cushion. So air cell, often, if that's stable enough for this client group, sometimes it's not. But within static seating, air cell should be fine. But in wheelchair seating, sometimes that can have its own challenges and compromise for stability. So yeah, it will be a very individual assessment, but it can be that you're swapping out your seat cushion options in your seating to add a third-party cushion that may address a higher risk need. Would you say that, Tristan?
Yeah, there's lots of different options when it comes to cushions. I think a key thing to start off with, though, is probably seat sizing, because if the seat sizing is wrong, then you end up with all sorts of pressure issues. So that's probably number one. And I think we've all seen the no offense to district nurses, but we've all seen it where pressure cushions are put on top of chairs and then people's feet aren't touching the floor because the seat's too high.
Yeah, and see it all the time.
That 19% of the body weight that actually usually goes through the feet then goes through the seat, which is actually adding pressure, not reducing it. So I think that's kind of a key point. But in terms of seat cushions, now on a lot of chairs, including the Lento range, you can actually take the cushion off and you can replace it with any type of shape cushion or specialist cushion. And there's a lot of different ones out there now. We've had quite a lot of success with the STX cushion, which is on the similar ones out there as well, but they're kind of like configurable cushions, so you can take the cover off, and there's a lot of different kind of
gel clusters. You could have the gel clusters at the back, or foam clusters, or you can add the woven air. So
you can almost build a molded cushion from a kit, really. So there's lots of different options now, and as Joe said, the air cushions as well. But it's really about doing that individual assessment, seeing what they used to have, they had pressure injuries before?
Yeah.
Is it for a specific individual, or is this chair for wider use in a hospital, etc.? Always better to go kind of higher pressure relief than kind of middle, where possible.
Yeah.
Another question. Do you have any examples you might consider for head support for
I
seating
read that one.
alongside orthotics?
Yeah, for
I work
MND.
as an
Yeah.
OT in MND. Yeah.
Yeah, I read
Yeah.
that question, and it's such a challenging head presentation within later stages of MND, with the typical kyphosis and real heavy, low tone, floppy head. It can, and even again, adding real specialist head supports with the front band or the front, you know, pads. It's whether they can tolerate that, because I've just, again, most weeks see a client with see clients with MND most weeks, and the head is so difficult, and it will be however much tilt and recline we add in combination, it's still, and the same with this gentleman with leukodystrophy, very similar head presentation. The weight of the head is so heavy, and the pull of the force is so heavy that the loading on these frontal supports is almost intolerable for them. So it has to be used in combination with some orthotic collar. Then there has to be a risk assessment with that, and speech and language are often involved with swallow. But I don't really like mentioning brands, but there are several, roller coaster, RMS, Whitmire, Sunrise, Eye to Eye. They're all similar head supports which offer advanced, bespoke, complex head positioning, but the setup of them needs to be very detailed, needs to be reviewed frequently, and sometimes I've done all of that and still the person rejects it, and they just want to be tilted with recline and pillows because Anna collar. It's just so difficult with that client group and that complex head, which is literally head, chin on chest. So, but there are head supports out there, but in the later stages of MND and this other guy, leukodystrophy, it is purely a very difficult thing to control and manage.
You mentioned about that's pretty key, isn't it? Trying to get the head back. We also offer some specialist head support for the chairs. So there's one that comes over the back of the chair, and it's multi-adjustable, almost like what you'd see on a tilted space wheelchair.
Yeah.
Yeah.
They are more so designed for wheelchairs than static seating, aren't they? But you can include them with the correct accessory bars. Yeah, you can fit them. Yeah.
Absolutely. Just looking through, for people who may require extra support, is it possible to add a chest harness and or lap belt? Well, it certainly is on our chairs. Did you? This is kind of a bit of a can of worms, shall we say?
Yeah.
With the whole restraint versus safety, etc.
Yeah. So yes for postural control. Absolutely yes for postural control. The correct postural accessories for pelvic positioning aids and chest positioning aids can make a huge difference in postural outcomes. As long as they're set up correctly, the correct size, the correct pull, the correct design and fabric, but they're so often incorrectly used and incorrectly set up. And become dangerous because risks when you're not there, when it hasn't been adjusted correctly, and you see harnesses up right under, the neck. And it was never handed over or set up like that, but somebody's fiddled with it in a multi-agency environment, lots of different experience levels. So as long as it's somebody that you're confident it will remain a postural element, not a restraint element, because that's a whole other thing, then yes, it can make the difference between a successful postural outcome and not. But there's a wealth of differences in how they're set up and the correct choice of product.
I'm just looking through the questions. We've got quite a few, but we've only got a few minutes left. So how might you improve the positioning of someone's pelvis, which is rotated, can be corrected, but have been sitting in this position for many years and cannot be maintained? So yeah, interesting one.
Yeah. So again, I would definitely look at them in lying, see how much pelvic correction, as you said, there is pelvic correction achievable, and then how that translates into sitting. We'll have to use additional postural elements. So we'll have to use the correct contours in the cushion and a pelvic positioning belt and the correct pull. So we can be pulling to realign the pelvis and holding it securely in position. But again, that's only if it's correctly set up. So it's very achievable, but it's how consistent they're put in, how much understanding the care around has, how many people are fiddling with that pelvic belt setup, how correct they're placed in. It's all down to that. So it's down to the motivation of the individual, the care team, the family, as to how much correction you can get and what position is there in bed as well. Bed support. Yeah.
Thanks, Joe. I had a couple of questions on whether there are any good seating assessment forms and what to consider. Any comments on that?
Yeah, so a seating assessment checklist, this is something that you used to more often see being used than you do see being used now. There are many seating courses out there, and there's some standardized seating assessments that take place. I don't know whether for you to use individually or whether it's do your trust have an agreed seating assessment tool they used, or is it just for your own reasoning? But there are seating assessment tools that you can use, standardized and sort of not standardized, but more accurate and more informal. I don't use one myself anymore because I just note it all down. I start from pelvis up, and I'll just note correct seat depth, correct seat width, what's fixed, what's flexible, pelvic presentation, spinal presentation. I'll note all of these, leg alignment, foot positioning, and I in my notes I'll say measurements were taken in clinic, assessment took place of postural presentation, and I'll note it all. But I appreciate that if you're less experienced, that might be more daunting and overwhelming, but there are many good seating courses that will go through the fundamentals and basics of that out there.
You do have an ebook that's available to download from our website at www.vivid.care, which has got a kind of goes through how to measure for specialist seating, that kind of thing.
Brilliant.
But I know there is a couple of pages in there which show an example of a seating assessment form, so that could be a place to start.
Good starting point, yeah.
But if you are wanting to kind of understand a bit more about how to carry out a specialist seating assessment, this ebook goes through it. Looks like my colleagues put a note on the chat there. So yeah, please do download that and have a look through. Now we are at 1 o'clock, so I think we're going to have to wrap it up there. I know there's quite a few questions that we didn't answer, so apologies for that. But thank you so much for joining today. If you do need a demonstration or an assessment of any of our chairs, or want to try out something with an individual or learn more, please do get in touch with us. The email address is enquiries@vivid.care, or just contact us through our website www.vivid.care. Thanks so much for joining us today. Thanks, Joe, for all your insights.
Thanks for asking me, and thanks for everybody that joined. Appreciate it. Okay.
Thank you very much.
Bye.
Cheers. Bye-bye.
Bye-bye.